Spring into summer by looking younger. Call Vein Clinics of Hawaii to schedule your free consultation today. Facial and body rejuvenation procedures are designed to help you look and feel your best without breaking your budget. Reduce pigmentation, fine lines, wrinkles, scarring, and stretch marks with minimal invasiveness or side effects. Confused about which procedure is right for you? Call 427-5565 to schedule an appointment or visit veinclinicsofhawaii.com.
Aloha, Hawaii.
Now you're
it's
talking.
Time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
And, we patiently wait throughout the entire week to get together with you and talk story about your veins. And as you know, we've been talking about Vein Clinics of Hawaii, and they have 4 locations on the Big Island where they started. And then, of course, on Kauai, on Maui, and here on Oahu, where Dr. Juliff and I do our recordings of the program. And the website, Vein Clinics of Hawaii, has all sites on it and different appointment numbers and different email contacts. We'll give you some more of those as the program goes on today, too. Today, and we've all heard this word in the news, and I thought, boy, there's such a great fear of the word, and also maybe a misunderstanding about what an aneurysm is. And today, arterial aneurysm disease, which is that's why you're the doc and I'm the radio guy.
You have to practice, pronouncing some of those words.
I think that in your world, that they just say, okay, let's make up the most difficult words there are to work to make our profession. An aneurysm. Everybody hears the word aneurysm. Oh, poor guy, he probably died. Yeah. It can kill you.
Well, it definitely can kill you. It doesn't have to, and that's part of the reason why I wanted to talk about this today, because last week we talked about another arterial problem, carotid artery disease. And that's also something that can, suddenly be, tremendously detrimental, life-altering, with bad strokes and that kind of thing. But aneurysmal disease is another one of those things that it can attack, suddenly, and the repercussions can be tremendously detrimental. And somebody may not have one symptom before they have a fatal event.
Yeah, and that is a little bit different from a lot of things that we talk about, because many of you know that have been listening for a while that venous disease it comes on really slowly, and if it's symptomatic and it gives you problems and you go to a doctor, you can start mapping it, planning to deal with it, and you're probably going to carry it over a long period of time. Where some of these other things can come up after a bad weekend.
Yeah, right. Well, they can become symptomatic, after a bad weekend. That is not to say that it hasn't been around for a long time in any one individual. For instance, an aneurysm is something also, similar to vein disease. It's something that, happens, and then it slowly worsens over a long period of time, and then it becomes very, very important, and, unfortunately, at some point, possibly fatal.
Yeah, we're going to try and avoid that for you today. We want you to stay alive. But I think maybe just even defining what an aneurysm is would be a big help. Because from what I understand, you get a wall of an artery or a vein or wherever the aneurysm is. I don't know if you get a vein aneurysm or not, probably not. However, all of a sudden it changes. Something changes it.
Right. Yeah. There becomes a weakening in the wall of the artery. And actually, you ask about vein aneurysms. We see those too.
Okay.
They don't have the specific repercussions that arterial aneurysms have. But there can be a portion of whatever, and it can happen anywhere. I mean, theoretically, an aneurysm can happen in any artery throughout our body. Now, are there specific spots that they are much more common in? Yes. Sure, yeah. And I think part of that has to do with the likelihood of a part or an area of an artery or an arterial system for the wall to become weakened. And there's a variety of different ways that might happen. Atherosclerotic, just regular vascular disease, and there are biochemical changes that occur. But, be that as it may, it's an area of the wall gets weak, and then right in that area, the artery starts to expand.
Expand.
So
okay.
it looks like one side of a dumbbell. Like there's the normal artery going into it, and then all of a sudden you have this dilated area, and then after the aneurysm, then it goes back down to a normal artery is typical.
One of the things that you said, and I relate to trauma. I mean, you think that when something gets damaged, it's because it gets damaged by trauma of some kind. And I'm wondering if that is sometimes the case. Can you get hit where later an aneurysm will develop, or do they just what is it? What does make that wall weak?
Yeah, well, trauma can be a cause. Yeah, definitely. Now, the most common types of aneurysms, no, they're more related to genetics. For instance, aortic aneurysms are something that we definitely inherit from our parents and grandparents, and then also atherosclerotic disease that is also affecting the wall of the artery and leading to an area that's going to expand. But trauma is one of those causes for aneurysmal disease, definitely.
Okay, now does it move? Does an aneurysm move?
The aneurysm does not move. Okay, so no, because it is the actual wall of the
right.
Of
so
the
so that's unlike a clot, which will break loose out of a fragment of a clot. So how does it do it damage? Does it just virtually shut down that vessel?
Well, that's a good question.
So I come up with these, gang, every now and again. I'm surprised to talk with a good question. There's no such thing as a dumb question, by the way.
Yeah. That's absolutely right. But basically, two things can happen. And a little depends on where it is, which course it's going to take. But aneurysms either rupture, they burst and blood goes wherever, or they can clot off. And if they clot off, then that's a major problem too, because it's interrupting the blood flow to everything that's downstream. So, there's a variety of different locations, and, let's just mention that here at the beginning, where aneurysms commonly occur. And probably the two most common sites are in the brain. Right.
You hear this a lot. He suffered a brain aneurysm.
Yes, and those are called cerebral aneurysms because they're in the cerebral arteries. And that's a pretty common thing. Most people have heard about that. The other most likely site is in the aorta. And the aorta is the huge, big main blood vessel that comes out of the heart and goes down the middle of the body. And there's a variety of different locations in the aorta where aneurysms might occur, but the most likely place is in the abdomen. It's the lowest most part of the aorta, just before it bifurcates into the two main leg arteries.
Do they get large?
They do.
Yeah. Because I'm thinking that having this blood flow, the normal flow of blood from the heart, that it needs to get to the other end of where it's going. And if this aneurysm is slowing it down, in some case, it must have to stop it.
Well, the aneurysm, while it's developing, and over a long period of time, again, it develops. But for most of that time, unless it clots off, in which, there's going to be a sudden, change in blood flow. But for the life of the aneurysm itself, most of the time, the blood's just going through, However, as the aneurysm gets bigger and bigger, the wall gets, weaker and weaker. And the pressure, the arterial pressure, then it becomes more and more likely as it's getting bigger that it will rupture.
Yeah, but here's the job. Here's the thing. Everything you've told us so far about this is bringing the nutritious new blood into your system.
Correct.
So when that gets impacted in any way, it's a danger. How do people find out about them? Is there an incident that's going to happen, or what? When does somebody even get diagnosed? How do you diagnose one, or what is anybody looking for?
Well, there are symptoms associated with aneurysms, definitely, and that's one of the things I want to talk about that fairly extensively here in a minute. But because, again, this is one of those things that people can be having symptoms from, and they don't know about it,
sure.
Unless people like us talk about it and fill them in. But and the symptoms are related to where in the body the aneurysm is occurring. So, like I said, brain aneurysms and then abdominal aneurysms. We call those triple A's. I mean, there's the sort of the short term abdominal aortic aneurysm, but aneurysms can occur in the aorta in the chest. Just about every level. Another more common aneurysm after abdominal aortic aneurysms are something that we call popliteal aneurysm. Those are aneurysms in the main artery that goes behind the knee.
Aha! Okay, now we moved.
And this is a new, new aneurysm. It's not like the aneurysm has moved.
No,
it's just another area.
Another area.
So those are pretty common now. And it depends a little bit depends on the location with respect to what is going to happen to that aneurysm. Abdominal aortic aneurysms rupture. That's primarily how they cause havoc.
Sure.
Popliteal aneurysms, on the other hand, those are one form of aneurysm that can clot off abruptly, and suddenly you've lost all blood flow from the knee on down.
Very bad.
And the likelihood of a patient having that and losing their leg over some long period of time is quite high. So
let's talk about maybe for a minute the size of the group that is likely to suffer these. I mean, I do know that from some of the stats that you gave me that it's certainly not rare, but it's not going to happen to 1 in 5 people. I mean.
No, it's not that common. But 5 to 10 people out of 100,000 in this country.
Now, that doesn't sound like a lot, but Doc Juleff has done this before. He's saying, okay, I know it's only 10 million, but you got to go with 350 million. So then when you take up that 5 or 10, now all of a sudden it's several thousand. Yeah. So now you might be one of those several thousand.
Well, and you're right. Those numbers don't sound too intimidating. But here's another statistic. The CDC reports that aortic aneurysms cause 25,000 deaths per year in this country.
Now you have my attention.
That's a substantial
big number. You bet.
Yeah. So aneurysmal disease is very common. It's a little more common in men over the age of 60. It's a very common thing, and it's something that can be lethal. Now, brain aneurysms, they're a little less common. 30,000 brain aneurysms rupture in this country per year. 40% of those people will die. So
I was going to say, it sounds like when you say rupture, now you really have my attention. Yeah, because that's the life-threatening part of it.
Exactly. Yeah. No matter where it is, it can be life-threatening. Okay. So, what are the risk factors for aneurysmal disease and like so many other forms of vascular disease? High blood pressure is one of them. Atherosclerosis, hardening of the arteries.
Yep.
If you tend to form plaque in arteries, as some people do, then you're at a little higher risk of developing an aneurysm somewhere. Hypercholesterolemia, smoking, injury, as we talked about. Genetics, if people have aneurysms in their family, then they need to be a little more concerned. They need to be a little more proactive in their thinking with respect to, might I be having a symptom of this?
Okay.
And then there are things like Marfan's disease. I don't know. Have you ever heard of Marfan's disease?
I have not. I thought that was No, I was going to say a candy bar, but I won't do that. Yeah.
It's a connective tissue disease, and people with Marfan's tend to be very very tall. They have very long fingers, and there's a variety of other things, but they're a little more prone to aneurysmal disease. So there are a number of disease processes out there that you might have that would make you a little more prone to developing an aneurysm and it leading to rupture.
What about subsequent aneurysms? I mean, can you be aneurysm prone?
Well, yes and no. If you have an aneurysm in one location, you're a little more likely to have an aneurysm in another location. For instance, aortic aneurysms. There's a good percentage of those people that also have popliteal aneurysms.
I get it. So,
So with respect to that, that is true. So, and then causes of, we're going to be kind of going back and forth between cerebral aneurysms and aortic aneurysm. Because those are the two big categories, and they're a little different. But with respect to the causes of aneurysms of the brain, they're basically the same thing: high blood pressure, smoking, cholesterol, atherosclerosis, etc.
Yeah, take your pick of all the good stuff. But I think one of the things that my ears perk up right away, because obviously we display this, we sort of explain what the thing is, and then of course you start looking for diagnosis and then treatment. I know we're a little bit early for that yet, but that does sort of get a listener ready to, okay, what are the roundabout ways that I might get this, and more importantly, how can I find out about it and what can be done about it?
Right. So, I think the first question is, for those people out there listening to this program, the first question is, might I be prone to developing something like this? And again, do you have...
How many of these things do you do, right?
Yeah, right. How much do you smoke?
Yeah, exactly.
How much have you, not treated your diabetes probably adequately? Do you have a family history? So all of those things, I think, those things need to trigger the idea in any one particular person. I might have something like that, so what are some of the symptoms that I should be looking out for? So the symptoms of aortic aneurysm and aneurysms in general, it depends on the location. And as far as aortic aneurysms go, we kind of categorize those into abdomen and chest, and then there are, like I said, extremity aneurysms.
When you say abdomen, because you told me off the air too about abdomen.
Yeah.
Where in the abdomen? I mean, is it? It's the abdomen rather than the stomach. It's in the somewhere in that area where there are arteries and veins.
Yeah. The aorta runs down the central part of the body.
Yeah, right down the middle.
Right in front of the spinal cord. So it's not like it's not close to the abdominal wall. It's set back a little bit. But that doesn't mean it's not going to, it can still have symptoms, although they can be hidden sometimes. There's no question about that.
Well, that's a big area, isn't it? It's easy to hide.
Yeah. And it's not like it's, when you see somebody with an abdominal aneurysm, sometimes you can actually feel the aneurysm.
Wow, geez.
It's a little higher than you would normally think. Often it's just below the chest cavity, the ribs.
Are there symptoms?
Yes. So the symptoms are sort of related to what state the aneurysm is in.
Okay.
And
pain. The number one I look for is their pain.
Pain. Yeah. Well, definitely pain.
Yeah.
But so the aneurysm can be in a state of enlargement. And that's the natural history of an aneurysm. It just slowly gets bigger with time.
And by the way, Doc is making with his hands, if you could see us, a size, and it made me ask right away, how big is a large aneurysm?
Well, we get concerned about an aortic aneurysm in the belly once it reaches somewhere around 5 centimeters. So
which is about
3 inches.
Yeah, that's pretty big. It's like bigger than a golf ball.
Yeah,
smaller than a tennis ball.
Yeah. So it would be it would be a good visual there. So just by the state of the aneurysm slowly enlarging, sometimes that will create symptoms. Pain is one of them.
Sure. Well, eventually getting bigger, like you're talking about, wouldn't that start putting pressure wherever it went?
Yes. Yeah, in whatever location.
Sure.
So, if we're talking about an abdominal aneurysm, sometimes it will create back pain, actually.
Yeah, I was going to ask about that.
Sometimes it will create pain that kind of goes, from the flank and down into the groin. And when people go into the hospital, sometimes with with an enlarging aneurysm and sometimes a ruptured aneurysm, the symptoms can often be confused with a kidney stone, because a kidney stone
there you go
can create a pretty fair amount of pain also, and it's in that same area. I got
to tell you, I've got a cousin, and the 5 words out of his mouth every time you hear him, see him, is, "Oh, my aching back."
Yeah,
and I'm thinking, why would you put up with an aching back? And it's he actually went to a back doctor or a doctor that was a back guy, and there's nothing wrong with his back. Mm-hmm. Of course, he's got all kinds of other things inside that are wrong, that are giving his back pain problems.
Right.
So this is not uncommon, is it?
It's not. Yeah. Back pain can be from the back. Yeah. But it might not be from the back. And so,
the guy says, "I don't lift anything. How can I have back pain?"
Yeah.
Well, you lift yourself. He's a pretty big guy.
Yeah.
That'll do it.
Yeah. So now, and then the other thing is just a pulsation, a prominent pulsation in the abdomen, and again, it's fairly high in the abdomen. But if you look at, you have to be pretty lean. But in some lean people, if they're laying down in bed, you can actually see the pulsation of the aortic aneurysm, and again, it's right underneath the rib cage.
Yeah, there's lots of ways, by the way, that people start looking at this, and one would think of, all right, pain is pain, and here's a symptom. But I know people that put up with symptoms all the time. Oh, yeah. We've learned little by little on this program that symptoms are really good, but only if you do something about them.
Yeah, only if you recognize it. Yeah. And so often they get ignored, unfortunately. But so chest aneurysms, they can also cause pain, more so in the back. But a new cough.
Okay.
Difficulty swallowing. Now that's from a chest aneurysm is higher in the chest. It may be impinging on lungs and the trachea. And these types of things, the esophagus, and there's a lot of stuff going on up there.
Well, I constantly hear this, and I'm sure you do too. People say, "Well, I don't know what's the matter with me. It just has constant." He's always complaining about his heartburn, or he's always complaining about his gout. Didn't have either.
Right.
And so what you have is a lot of these symptoms that we're talking about here can be indicative of a problem in a number of areas. For instance, look at the amount of times. This is slightly off subject, but if you've been following the show, I do that a bit. And that is when we've talked in the past about when a dermatologist passes on a patient to you because he's been treating a rash on skin for months that doesn't go away, or vice versa. When you see something that says, this is not a venous thing.
Right.
So what I'm getting at is that a lot of people that are listening, once you self-diagnose based on some misinformation, you're actually really putting yourself at risk.
Yeah, that's true. And, the way to look at that is that most symptoms, 90% of the time, a symptom has a reason or a cause. And so, and it's not, if you're having, significant kind of symptoms, then it would behoove you to kind of go wherever you need to have it fully explained.
Okay,
to you.
Now I do know in this age of specialization that it is not unlikely that you're just going to be kicked down the road. If you go to somebody for something that you thought was in their milieu, they're going to be, through the normal process of their diagnosis, they're going to know whether it is or not.
Right.
And so they're going to say, the good news is you came in to see me. The bad news is I got to send you somewhere else.
Yeah.
Or it's not necessarily bad news, but the good news is I'm putting you somewhere else where they can help you.
Sure. Yeah. And we do that all the time.
Yeah, of course. Yeah.
We see people and they have venous disease, but they also might have, heart problems and or lung disease that have not been fully diagnosed and treated. So we send them to whoever we think should see them.
Yeah. Doc, I think that sometimes this comes as a blessing. People will go to you for a vein disease. They'll get treatment, and at the same time, they'll really identify another concern they have and realize that, it's maybe it's not as cosmetic as what they came in to see you for or as symptomatic, but it all goes to how they're going to enjoy themselves or not. By the way, you go to veinclinicsofhawaii.com and check on this stuff. veinclinicsofhawaii.com. See all the things they do, including some kind of fun stuff. You got to drop in. I was there the other day and talking to this young lady that was waiting out in front to see somebody, and she was just there because she heard that you did some really cool stuff there. You know, you have some of your staff guys and gals have some fun.
Oh yeah, we do some fun things there too.
Okay,
absolutely.
And you know, this program is also designed to not necessarily make you have fun, although we do seem to share a fair bit of humor during this, but it is just so that you can sort of feel very comfortable into making an appointment or coming in to see us. And one by one, it's I call it the reverse bucket list. Start checking things off lists that you've just been writing down for a lot of time and not doing anything about.
Right. Yeah. And like we keep saying, there's no such thing as a dumb question.
Absolutely. I've done 3 of them already in the last 10 minutes. Yeah.
If you want to call up and just get our advice on the telephone, or tell us what's going on and ask us if we feel like we can help you, that is perfectly fine. We're more than happy to answer questions, and you should not feel intimidated in any way, shape, or form.
One thing that I've really come to appreciate, and I met another a couple weeks ago, we had a patient, and we sometimes have patients in here, and we'll going forward as well. But this guy was so relieved. Some of these people get so relieved when they get a very basic question answered that it's like you can see the cloud lifted off their shoulders. And, geez, somebody help me, please. Now that I know what this is, let's get rid of it.
Yeah. Right. And we try to help people.
Okay, so
find that.
Once again, these aneurysms, you talk about, the size and everything else. It's when you discover one, what is its, here's the discovery. We know this. What do you do about them?
Well, there's a variety of different ways that we treat them, but I just wanted to cover one more thing here with respect to symptoms, and that is that, like I mentioned before, it's kind of the state of the aneurysm. Is the aneurysm there and not creating any symptoms, which it might be? Or is the aneurysm there and it's enlarging at a fairly rapid rate, and because of that it's creating symptoms like pain or whatever? And then also we have this state of the aneurysm being ruptured.
Yeah.
And obviously the symptoms there are a fair bit more dramatic.
I should say.
There's going to be pain, and the thing that happens is that it's always, when I was first learning about this stuff a long time ago, you think of a ruptured aneurysm and you think, the blood's going all over the place and that patient's going to die. And that does happen. There's no question about that. But there's a good number of patients that, especially with the abdominal aneurysm, they'll rupture and they'll lose a lot of blood
inside.
But we call it a contained rupture, where there's not free bleeding out into the abdominal cavity. It's sort of all contained within the tissue where the aorta is, and they make it to the emergency room. Now they're going to have pain. There's no question about that. Their blood pressure is probably going to be low. They're going to be kind of cold and clammy. I mean, at that point, I think most people recognize the fact that there is something wrong. Is
there a prerequisite that an emergency room be an igloo? I mean, every time you go into one of these places, it's like they give you 5 blankets in the middle of the summer. I guess that's part of the deal.
That's a good question. The same question can be said for the operating room. The operating room is always cold.
You can hang meat in it. I think that's a funny thing. Yeah. And I know it's for a lot of reasons. Certain germs don't do very well in low temperatures and other things I knew. But I still think that once somebody has an inkling, then they're more likely to associate a symptom with, maybe it's time to go do something about this.
Yeah. So, and that's why, I really wanted to spend a fair amount of time talking about symptoms, because we often have symptoms of these things before they get to a critical point. Many people have symptoms of an aneurysm before it ruptures, and that's what you want to pay attention to.
That's what you want, sure. Yeah.
So, for instance, brain aneurysms, there can be the same thing can be said for them. Some people have no symptoms whatsoever until they rupture, and that type of ruptured aneurysm, the brain aneurysm, can be as fatal also.
Is there with the brain aneurysm?
Yeah.
Is there also size involved in it? I mean, some of these other ones you're talking about. In a body cavity, they get pretty big.
Yeah.
But I would imagine if something started to present itself on your head, you'd know about it.
Yeah. Typically we're talking about much smaller arteries.
Yeah, tiny little artery. Yeah.
And consequently, the aneurysms that occur there are much smaller.
Sure.
Yes.
Okay.
But they can also cause symptoms. When I was talking before about an expanding aneurysm, well, those aneurysms are creating symptoms because they're getting bigger and they're impinging on other things.
They're
like
pushing
nerves.
things that may let themselves get pushed.
Yes.
Or not.
Yeah.
There you go.
And there are things that may, when pushed, they're going to scream back a little bit.
Yeah, of
and
course.
Those are the symptoms. So, an unruptured aneurysm in the brain sometimes will cause, visual kind of things. Pain behind one eye is one of those signs, Can
it be excruciating?
It can be, it can be severe, or not. Maybe it's not that bad, but it can be severe. Sure, a dilated pupil can be a symptom. One pupil.
How would you like to look in the mirror and say, "What the heck is that?
Why is my pupil dilated?" Changes in vision in general. Double vision, blurred vision, that kind of thing. Numbness on one side of the face.
Mm-hmm.
So all of those can be symptoms of an aneurysm in your brain, not ruptured. It's just there, and that's the time to find out about it. So now what happens when that a cerebral aneurysm starts to leak or it ruptures? Pain, basically, a severe headache, and many people will talk about a headache due to a vascular event in the brain as being like the worst headache I've ever had.
Yeah, I've heard that before.
When people come into the ER, that's what they're listening for. This is the worst headache I've ever had. So that can be, sort of a pointer as to what's going on. And
let me ask you this. Are you sometimes amazed at how much pain some people can handle and others can't?
Yes.
I am. I mean, I've always thought I'm a big dude. I'm a crybaby. I mean, in some way, not. Yeah. I mean, I've broken things and not shed a tear. Mm-hmm. But I can tell you that sometimes you can have a mental pain.
Oh yeah.
When you get news about you're this or you're that. But I'm amazed that when you say somebody had a headache, that how they can even function, and some of them can't. Mm-hmm. I mean, that's what I just don't understand. How bad can it get? Well, it can get really bad.
Oh yeah. Sure. That's the kind of pain that that pain is something that people are not going to ignore. I would think most times.
I should hope. Yeah.
And the other thing about cerebral aneurysms is that they can bleed and then they can stop. So it'll what we call leaking. It'll be kind of a leaking. Now, and that also is sort of a sentinel sign. We call that a sentinel bleed, and it can create sudden symptoms of the sort that we've been talking about, and those symptoms might go away completely, But even though that symptom was short-lived and it eventually went away, it's not something that you should ignore. Yeah. You should look into it. And so some of the other things, if a cerebral aneurysm ruptures, then, not only pain, but nausea, vomiting, stiff neck, visual problems, sensitivity to light.
Yeah, and incidentally, I think this is fascinating because if you've been a regular listener to the show or you've talked to any doctor at any time, every single symptom that we're talking about, and this is why they ask you 10 million questions even when you're in an ER, because so many of these symptoms can be indicative of just this wide myriad of problems. You need to, as a professional, start taking away what not to be true so you can get down to the base.
Yeah, people come in with a whole host of symptoms that, may be related to a half a dozen things, but when you look at them all together, together they usually point to, one or two that you can narrow it down.
The reason why I said that is because I had to laugh the other day when this guy was being asked by the doctor do you suffer shortness of breath? And he said, no, I'm fine. And the wife said, no, you're not.
Right.
Because he does, but he doesn't realize that he does. And until you walk a mile in his shoes, you don't know what he's going through.
Yeah. It's just that he's been short of breath for many years and just kind of grown accustomed to it. But anyway, so seizure, some of these other things, seizure, drooping eyelid, loss of consciousness, confusion, all that stuff can happen with a ruptured aneurysm. And again, those are things that people are not going to ignore. And typically they'll, go to an ER and try to figure out what's going on. So, okay, so getting back to your prior question, let's say you think you have an aneurysm. Yeah. Well, probably the easiest and quickest and what we do typically to screen for aneurysmal disease, and we talked about screening for carotid disease last week, is ultrasound. We use that for all sorts of arterial disease, and so that is going to immediately tell us, well, gee, this patient is having abdominal pain and he had this and that. Is an aneurysm the reason for it? It takes 3 minutes to look at that. Yeah,
and let me ask you this. I think he's already answered it, but you need to know this: the ability of the ultrasound machine is just a machine. It really depends on who's operating the machine as to what level of expertise they've developed, what experience they've had, and the ones that I've met of yours, especially Michael, who's done a couple of things to me, they are just as key about learning as they are about explaining. So I think it's incredible that this piece of equipment can be used almost everywhere on the body.
Yeah, it can.
It's amazing, isn't
Virtually
it? Yeah,
everywhere.
It really is amazing.
Yeah.
So let's talk about, I would imagine that a lot of these things that we're talking about now were fatal before the ultrasound came along to nip it in the bud quick enough so they could get treated.
Well, they were fatal because there was absolutely less screening going on back then, sure. And it made looking at aneurysms and following them over time, much more different than we do today.
Yeah, sure.
Because we see a lot of people who we find out have an aneurysm, and there's a variety of different ways why you might pick that up. I mean, you can sometimes you can see an aneurysm just on a regular X-ray, but we then want to measure that aneurysm. We want to find out how big it is, and we see plenty of people who have aneurysms that are less than where we need to start to get very concerned about it.
Yeah, I get it.
And so,
very early stages.
Yeah, so if we see somebody with an aneurysm, it's a small aneurysm, but it's an aneurysm.
Sure,
we don't just say, see you later. You don't have anything to worry about because, again, the natural history is for these aneurysms to slowly get larger with time. And we will, we might in 6 months or 12 months, depending on the size, say, come on back, let's do another ultrasound. We need to follow this thing.
I almost got a chuckle because I heard that when somebody said, well, we've noticed a couple little cysts on your kidneys or liver, whatever it was.
Yeah.
I said, really? What are you going to do? Well, we're going to take another look. So after angsting for about a week, I find out, okay, they're not a problem. They're small.
Yeah.
They're not malignant. So you have them. I said, well, wait a minute. I don't want them. There's nothing that justifies treating them if they're not an issue.
Exactly.
But every now and again, isn't it amazing what, let's say a patient is in there for a follow-up vascular issue that they've had with you, and all of a sudden when the ultrasound says, hey, wait a minute, hey, just a minute. Mm-hmm. And then he looks it over and says, Doc, I think you better come in and take a look at Molly here because there's something going on.
Yeah. And that happens all the time.
I bet, all the time.
People might get, an ultrasound for their gallbladder or whatever, and, either kidney cysts or liver cysts or aneurysms or whatever are seen, and that's a good thing because then we at least know about it. It's a little disconcerting if you don't understand the whole thing because it's like, well, I'd rather not have that. But,
well, I was just thinking, is this something that I want to include in the inventory?
Right,
is it of any value to me to own these things?
Yes.
Probably no. Well, but isn't it true that there's some things that, number one, it just doesn't justify going in with a procedure.
Oh, yeah.
Because it's just not something that needs to be dealt with.
Well,
look at it, watch it, but,
sure,
don't fool around with it.
Sure. And and that goes to the risk of whatever it is that we're looking at.
Yeah.
And, when it comes to aneurysms, when an aneurysm is, let's say, 3 centimeters in diameter, the risk of that rupturing over some period of time is so low that the risk of having surgery to correct it is higher.
Yeah, and see, there is the decision making. That's why, and I've always enjoyed this ever since I met Dr. Julev, that you are explained one-on-one where you are, what's going on with you, what the options are, what the recommendations are, and what's if you could call a shot, to what would you want? And isn't that the main reason why your relationships between you and your patients is as good as it is? I would think.
I would like to think so.
Yeah, that's
sure.
what they say. I mean, your staff says that. We talk about you all the time behind your back.
Oh, okay. That could be good or bad.
Yeah. But seriously, I mean, I think that everybody likes to be proactive, but they also want, before any decision is made, say, all right, have we looked down every alley here? I mean, if I don't want to do this, is there something maybe less invasive that I might try first?
Oh, yeah.
You
sure.
do all that, right?
Yeah, right. Absolutely. So we use, again, ultrasound extensively for aneurysms of the belly because they're very visible through with the ultrasound. For aneurysms elsewhere, and we do it for the lower extremity, too. So if somebody has a popliteal aneurysm,
behind their knee,
behind the knee, we follow that.
How far down the
ultrasound.
leg can you get one? Can you get one in your ankle?
You could.
Yeah, but not likely.
But very, very rare.
Yeah.
I don't think I've ever seen an artery, that far down that has become aneurysmal.
The reason I ask is because we've not heard aneurysms and diabetes mentioned in the same breath. So they're just, not necessarily partners ever.
Well, they're not always partners, but are they, potentially partners? Yeah. So for aneurysms, especially in the upper abdomen and chest, we rely pretty heavily on CT scan. And CT scanning also is a very, very good modality. Gives us a great picture of what's going on. And we can, with a CAT scan, basically we can, answer both of those questions. Number one, should we operate on it? And if not, number two, we can use CT scanning for screening or for following those aneurysms over a long period of time.
Okay, so what happens when you make a decision? All right, let's get the gloves out. Let's deal with these. What sort of treatment procedures are there for what level of aneurysm? So the first question is when to operate on an aneurysm. And for it, and again, it depends a little bit on the location. For abdominal aneurysms, we wait until they're about 4.5 or 5 centimeters. Okay.
And there are set numbers for, different, parts of the aorta or other, peripheral arteries. But in general, if that aneurysm has expanded to 2.5 times or more the native normal artery, then it becomes
now you need to treat.
Yeah, then we need to do something about it. So now we're doing the gold standard always until recent years, and by that I mean 15 years. The gold standard for treatment of any kind of aneurysm was surgery. And
sometimes they're pretty big. I mean, sometimes you know exactly what you're doing. You open the person up, take out their aneurysm or whatever. Yeah.
Well, and the way that we do that is that we actually don't take out the aneurysm. The aneurysmal wall stays in, but we open all of it up, and we basically what we do is we just hand sew a cloth tube, into the top and the bottom. So we're sort of making a new little length of the aorta. To take the place of where that aneurysm used to be.
So is it like mesh? You know, I mean, is it like a gauze or?
No, it's a Dacron.
Okay.
Most of them are Dacron, pretty firm cloth kind of material. I mean, you know,
so your body's going to grab it.
Yeah, well, your body's going to incorporate it into, you know, I mean, you develop a lot of scar tissue around a cloth graft, you know, when it's put in surgically. But you just your body incorporates it, and it works great. And it's probably the most even now when we talk about abdominal aneurysms, and there's other ways to treat those now that are less invasive. But as far as the durability of the repair, you know, surgical replacement of the aorta in the area where an aneurysm was is still probably the best way to go.
Yeah, that's interesting. And by the way, some of you that already done that, you know, unfortunately, this is a recorded program. You can't call in to join us, but you can tell others if they say, you know, I had this and I've had that. What you really want to do is go to veinclinicsofhawaii.com and click on contact me or contact them with a question that you have, because even if we could talk to you live on the program, it's pretty hard to diagnose over the airwaves what's going on with somebody.
Sure.
There's so many different things. But I think that once you're on the path where you've decided to recommend to your patient and the patient's ready to accept treatment, they want to know, okay, what's the plan? How do you do this?
Sure, yeah. Now, you know, the one drawback to surgical repair is the fact that it's a big operation, you know, no matter where you're doing it. You know, it requires fairly large incisions, and, you know, the typical way that we repair an abdominal aortic aneurysm, again, it's a big incision all the way up and down your belly. And people are in the hospital, you know, 5, 6, 7 days.
Wow.
It takes, you know.
Not like the vein clinics. Walk in, walk out.
Yeah, not like doing vein procedures, definitely. Yeah. And there's a certain amount of mortality and morbidity associated with that operation. It's not uncommon for most people to have, you know, an overall mortality of, you know, 3-4%. That's substantial, you know.
Yeah.
And so in more recent years, we have the new technology that has been developed is a percutaneous device that is actually able to go up. Again, we thread, you know, a wire and a catheter and all that sort of stuff into the artery, and we're actually able to load those graft materials
right there in the instrument,
into the instrument in such it's in a small compact way that we're then able to thread it up into the aorta where the aneurysm is, and then from the outside release that graft material. Yeah. And it's got little prongs that come out and hold it into the wall of the aorta, and it's tremendous. I mean,
the goal is it's a pipe going right through what used to be a problem.
Yeah, exactly. It's a pipe through a balloon.
Is it similar to we've talked in the past programs about stents, about, you know, things that you put to either reinflate a vessel or strengthen a vessel? Is it similar?
It is very similar. Yeah. As a matter of fact, we call those stent grafts.
Okay, good.
Because I mean, it's a very same principle. We're using X-ray, we're using fluoroscopy, and a little bit of angiography, and we're able to again direct these things into the location where they're at. And it's great. I mean, in the mortality of getting through that procedure is a fair bit less than what we call an open surgical approach. And in people, the hospital stay has gone way down. I mean, people are coming into the hospital, literally spending one night in the hospital after a stent graft placement and going home feeling pretty good.
Yeah, I can tell you that hospitals these days aren't saying, go ahead, give us the forwarding address. You know, give us as your address, because their object these days, particularly because of the escalating cost of what those beds cost every night, you got to turn them. They got to, you know.
Yeah, sure. So that has been great. Now,
how's recovery? I'm sorry. Yeah, how's recovery from one of these surgeries?
Yeah, well, the recovery from a stent graft is pretty easy.
Yeah.
Like I said, people are in the hospital for 24, 36 hours. They go home and, they take it easy for a week, but then they get back into their usual routine.
Good.
If we do a surgical approach, then they're in the hospital for, the better part of a week, because it takes that long getting in the recovery. Even at home is much longer. But the main difference between surgical repair and using a stent graft, which is easier getting through the procedure, the follow-up for the stent graft is a fair bit more extravagant, because of the fact that we have to do CT scans on these people periodically, basically for the rest of their life, because those stent grafts can move and migrate and create problems.
Yeah, but the good news isn't it, Doc? The good news is that now you're treated by your physician.
Yeah.
Your records are, if something should happen, the physician is retiring or moving or going away, the records keep going forward. Now there's a pretty good file on you, so anybody that's of the modern age of medicine like yourself will be able to pick up a file on me and get a pretty good indication of where I am and what I might need.
Oh, yeah.
Yeah.
Definitely.
I think that's important.
Yeah. That's, the electronic medical record has added a lot too.
By the way, the reason I said that is because during my ultrasound in doctor's office the other day, there's this really neat cartoon, not a cartoon, a drawing of me. And there's a way that the operator of the ultrasound makes these notes. And that goes in your file and it goes forward. So it's pretty easy, especially if you're using the same kind of equipment with the same amount of skilled technician, that you got a pretty good carry forward thing. So as my doc, you pick that up and say, okay, this is September. Let's look at it today.
Sure.
And there's you can tell immediately what's up.
Yeah. Most of our, reporting methods are pretty standardized. And and that's important because people are very migratory these days, and if they need follow up from whatever disease process, it's nice to have all those records able to be transferred from one place to the other.
Boy, amen to that. I got to tell you that I saw my records. I'm a multi-generational Straub baby. Straub's been a part of my life for decades and decades, and I've seen the transition from these things that used to be around. They used to have a wheelbarrow going around from doctor to doctor with my file, which was like 3 feet high, because I've been there forever. And now it's like click, and they just bring up on the monitor what particular file they like. Great help.
It's been really nice. I mean, it's they're a little difficult to deal with on a day-to-day basis sometimes, but it's been a tremendous help just to kind of
somebody's got to load it in there though. At the end of the day, somebody's got to put me in that thing.
And it's often me, and I don't like that.
I get it. All right. Well, anyway, but I still think, and then obviously depending on where the aneurysm is, what the surgery is, that there's obviously going to be a follow-up, and then somewhere in my chart you're going to start remembering, I had that, let's keep an eye on other parts of the same part of the body that might also be susceptible.
Right. Yeah, well, that's actually that's a good point. With respect to follow-up is to keep track of other related either aneurysms or vascular diseases or just disease processes in general that might be related. Absolutely.
Yeah, and that's really all good stuff, gang. And one of the reasons why we want to look in on that is because if you were with us last week, every week we talk about a different form of the disease, and there are chapters and subchapters. But the good news is that once you get on that gradient curve that you keep on all your patients, you know where this guy is or where that gal is, as far as during the 6 stages of venous disease in the venous disease. But same with these other things. They must have a similar chart, a similar record-keeping system.
Right. Yeah, there's a classification process for just about everything.
Well, I hope that you've enjoyed the program today, that you've learned a little something. Vein Clinics of Hawaii on the Big Island, Kauai, Maui, and here on Oahu. Go to veinclinicsofhawaii.com and check it out. I told you earlier, there's lots of other stuff that happens there. Let me tell you, before we say goodbye, let me tell you about this.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Spring into summer by looking younger. Call Vein Clinics of Hawaii to schedule your free consultation today. Facial and body rejuvenation procedures are designed to help you look and feel your best without breaking your budget. Reduce pigmentation, fine lines, wrinkles, scarring, and stretch marks with minimal invasiveness or side effects. Confused about which procedure is right for you? Call 427-5565 to schedule an appointment or visit veinclinicsofhawaii.com.